Anyway, the point of this lecture is to take everything we've discussed to date and put it together as one. So we talked about renal hemodynamics, we talked about salt and water, we talked about potassium and acid base, and so it all comes together as one. These things don't happen in isolation, but we've discussed them all in isolation. So to have one lecture as such, bringing it all together, and then we move forward and discuss clinical cases that relate to salt and water problems, and then move on to next year land. So as you hopefully you've noted also in OPAL, it says that if you have a Mac, and most of you have those little apples facing me, for some reason this file causes Macs to crash. I don't know why that is. It is actually quite heavily animated, but it's not that big a file. So that's why I've uploaded with a PDF also, or just watch it here, because really the animation is the best part of this, and the thing that I'm most proud of, because this is my own artwork. So don't be too critical of my artwork. Done with PowerPoint, no less, not being an artist. Okay, so this is the, and hopefully all of this, you know all this, and just this is, hopefully will be a review, but also help integrate things for you. So this is the nephron, and that hopefully you're now intimately familiar with. And the cortex medulla, this line separates the cortex from the medulla, and I'm not going to go through those again because you know all that. But to go through this, then, this is actually a PDF of everything that you needed to know that I discovered class of 2012. So that would have been 2009 when I was actually helping someone who was doing a supplemental exam, and they had this PDF file. And this is actually a medical student put this together. And he actually could look at this, and this is all you need to know. And as it turns out, this is Jamie Shaw, who was a Med 2 at the time he did this, is actually now a nephrologist. He finished his training, and he joined the section this year. So there's hope for all of you then. Anyway, obviously he was clearly interested in nephrology back then, and as hopefully he is now. But anyway, that summarizes everything. And he's obviously more artistic than I am on one slide. So to carry on then, this is to review renal hemodynamics first. This reflects the afferent and efferent arterial and the glomerulus and the peritubular capillary that I drew in there. So this is the blood going through here, urine forming and forming around the peritubular capillary. You recall the juxtaglomerular cells in the afferent arteriole. And you also talk about autoregulation of renal blood flow and then renal plasma flow, that over a wide range of blood pressure, renal blood flow, renal plasma flow, and GFR remains relatively constant. And you get a similar pattern with GFR. And this is controlled by this so-called myogenic reflex or myogenic mechanism, it's also called, which is the smooth muscles in the afferent arteriole, that when the individual is volume replete, this either dilate or constrict to maintain this constant blood pressure, and therefore this constant GFR traversing through the glomerulus. What happens in the situation when the patient is underperfused, for whatever situations occurring, whether it's somebody who has a low cardiac output from heart failure and has a decrease in what we call effective circulating blood volume, but is actually fluid overloaded clinically, or they're actually overtly hypovolemic and have a low cardiac output from that, systemic baroreceptors get activated, and the result is constriction in the afferent arteriole, illustrated by this here. This is constricting the afferent arteriole. I'm trying to illustrate here, resulting in a decrease in renal plasma flow. Whenever the constriction of the afferent arteriole or sympathetic stimulation in the afferent arteriole, the juxtaglomerular cells in the afferent arteriole release renin, and that results in ultimately in angiotensin II, causing constriction in the afferent arteriole to result in this balanced vasoconstriction. So you've got an overall reduction in an overall marked reduction in renal plasma flow with a lesser reduction in GFR. Hence, this filtration fraction goes up. And then at the same time, both the sympathetic system and angiotensin II stimulate prostaglandins, and the important renal prostaglandin is prostacyclin, PGR2, which acts in the afferent arteriole to dilate up the afferent arteriole so there isn't the intense vasoconstriction. And the net effect is a marked reduction in renal plasma flow, a less reduction in GFR, and an increase in filtration fraction. And that's what happens, again, regardless of what stimulated the sympathetic nervous system. And the kidney can't differentiate whether the individual is fluid overloaded, as they would be in heart failure, or hypovolemic, as they would be in volume loss or blood loss. And conversely, and similarly, they would, if they had constriction of their renal arteries, the same thing would happen. Constriction of their large renal vessels would cause the same kind of activation and balanced vasoconstriction. And then, as I've illustrated here, which we'll come to, this results in a decrease in perfusion through the peritubular capillary related to constriction in the afferent arteriole. This is relevant for a number of reasons. One is the use of pharmacologic therapy. So if we give somebody an ACE inhibitor or an ARB to block the renin-angiotensin system, an angiotensin II blockade, you then get this reduction in constriction of the efferent arteriole or dilatation of the efferent arteriole such that you have resulting in a decrease in GFR. And the same thing would happen, or a similar thing would happen if you gave somebody a prostaglandin inhibitor and inhibited this renal vasodilatory prostaglandin such that this is now constricted. Both will result in a decrease in GFR for different reasons. The ACE inhibitor ARB will result in the vasodilatation of the efferent arteriole. You don't get the balanced vasoconstriction. And the prostaglandin inhibitor will result in a decrease in vasodilatation of the afferent arteriole, so you get more intense vasoconstriction. Both result in a more marked decrease in GFR. And hence, the importance of appreciating what happens when the system gets activated, what maintains this, and how these drugs that are commonly used, ACE inhibitors or ARBs are obviously prescribed, prostaglandin inhibitors are available over the counter, so many people may be taking them. And it's only relevant, again, when the system gets activated, and not relevant when it's renal autoregulation of renal blood flow is controlled by the so-called myogenic reflex. Moving on then to the tubular system. So start with the proximal tubule, as amplified here. And again, this is my artwork, my cartoons, whatever it's worth. This again becomes the glomerulus, the proximal tubule. This is the lumen, the cells, the interstitium, and then now the peritubular capillary coming from the efferent arteriole. And I've called the osmolarity 300 to keep it simple here. We have filtered sodium and bicarbonate with urea. The anions could be chloride or bicarbonate. And what happens here is in the basolateral membrane, you have active sodium-potassium ATPase actively reabsorbing sodium into the interstitium. Sodium then passively moves down the concentration gradient. Chloride will go with it to maintain electrical neutrality. Urea will go with sodium and chloride. This is freely permeable to water, so water is reabsorbed. The urea concentration goes up, so urea is passively reabsorbed, and you have enhanced urea reabsorption here. And then it ends up in the interstitium. Both sodium, chloride, or any other anion accompanying the sodium and urea sits in the interstitium, determining whether it's going to be reabsorbed into the peritubular capillary or leak back into this falsely named tight junction. This is not a tight junction. It allows the solutes to leak back into the lumen and be excreted. So we also have at the same time carbonic acid being created from CO2 and water under the influence of carbonic anhydrase in the cell. And this then results in secretion of hydrogen that's exchanged for the sodium as a sodium-hydrogen exchanger. And this bicarbonate is the bicarbonate that gets reabsorbed. Really a misnomer calling it reabsorbed. It's actually regenerated from this carbonic acid. And this hydrogen combines with this. This is the sodium that's exchanged with the hydrogen. This hydrogen combines with that bicarbonate then to form carbonic acid. And then we have the brush border in the proximal tubule that contains carbonic anhydrase. This is how the proximal tubule differs from the distal nephron, where we also have hydrogen secretion because of the presence of carbonic anhydrase in the proximal tubule. And how sodium and water reabsorption is linked to regeneration of bicarbonate. Same time, we have sodium that's co-transported with glucose. The SGLT2 co-transporter is important here because this is now actually is a pharmacologic therapy for type 2 diabetes, an inhibitor of this transporter preventing glucose to be reabsorbed. And remember, there's a transport threshold of glucose that's roughly some 10 to 12 millimoles of glucose that's filtered from the plasma. Each individual nephron will have an individual threshold. All the thresholds together, when they're reached, is called the transport maximum. And when that's exceeded, you now have glucose that stays in the lumen, and sodium then will stay with it because of the osmotic effect of the glucose. So nothing we can do to change this active pump. The only thing that may alter this is glucose in the proximal tubule, and also if we give somebody a drug that inhibits this carbonic anhydrase, will limit bicarbonate reabsorption and hence prevent the sodium from being reabsorbed with it here. And then you have potassium being passively reabsorbed here down a concentration and electrical gradient. And what ends up happening is the sodium reabsorption is isoosmolar. There's no change in osmolarity. And we talk about this is the bulk reabsorption of salt water in the proximal tubule being this range of 55 to 70%, which is a huge amount of sodium and water when you think about the total amount of sodium and water being reabsorbed. And the question comes up is what determines whether it's 55% and leaks back into the proximal tubule or is reabsorbed into the peritubular capillary. So it's turning back to our renal hemodynamics. When this system gets activated and you have this hyperperfusion and stimulation of the so-called neural humoral system resulting in constriction here, and you get a decrease in the hydrostatic pressure coming from the peritubular capillary. At the same time, this constriction results in increased infiltration because of this increased infiltration fraction, such that you have more fluid being squeezed off, more protein for fluid being squeezed off, so your albumin concentration goes up in your peritubular capillary. The net result here is an increase in your albumin concentration, resulting in an increase in oncotic pressure, the decrease in hydrostatic pressure distal to where it's constricted. Those two things together will then favor more fluid with salt moving into the peritubular capillary, and therefore it would be 70%, and as opposed to 55%.
I just have one question going back to the SGLT2. If you inhibit that, and then so you're reducing the amount of sodium absorption, and as well as bicarbonate because it's all isomolar, do you also end up will that kind of diurese the patient a little bit? Because then will you be making more?
So Braden, right?
Yeah.
Did you grow a beard since I last saw you?
No, I just.
You always had that beard.
Last time, yeah.
Okay. Maybe your picture didn't have the beard. Okay. Great. Okay, good. So Braden's question was, is that if you inhibit that sodium glucose co-transporter, do you get a diuresis? That's your question. Similar to, would you get a diuresis if somebody had a plasma glucose level that exceeded the transport threshold, right? And the answer is, what do you guys think? Yes, you get an osmotic diuresis, absolutely. In fact, that's why people with uncontrolled diabetes have polyuria and polydipsia. And in fact, the drug, you're saying, well, wait a second, now by giving people that drug, you're going to induce these people to be polyuric and polydipsic, and actually that is the goal, to decrease glucose absorption. Okay. And interestingly, as you will learn probably next year in endocrinology, it's actually become a second-line therapy for diabetes because it's actually shown to decrease cardiovascular mortality and may have a renal protective effect. So actually, it's become a critically important drug in the treatment of diabetes. And one of the mechanisms is it causes a diuresis. Okay. And then, therefore, this is how we get enhanced sodium with bicarbonate that's sitting in the interstitium, sodium and chloride. And, of course, urea will also have an enhanced urea reabsorption in the proximal tubule, all because of these Starling's forces. And again, the osmolarity leaving the proximal tubule is the same. It's just a greater amount coming through there. So, again, as I've mentioned, you get an increase in urea reabsorption, and we compare the urea to creatinine. And we use this urea to creatinine ratio as a parameter when we look at someone who's got an elevated creatinine. We're going to start talking about this more tomorrow, in that someone's got an elevated creatinine, and our question is their creatinine elevated, representing a decrease in GFR? Is it elevated because they've got intrinsic kidney disease, or something's wrong with their kidneys, or is the kidney just underperfused? And we're going to be using these various parameters we've talked about to determine that. One of the parameters is looking at the urea to creatinine ratio. Because if you just have a decrease in GFR, and that's all that's happening, i.e. intrinsic kidney disease, the urea and creatinine will go up in parallel. If the kidney's underperfused and you've got an enhanced urea reabsorption, you've got an enhanced salt and water reabsorption in the proximal tubule, and an enhanced urea reabsorption, and as we'll discuss in a few moments, and also in the medullary collecting tubule, that's a clue that the kidney's underperfused and hanging on to salt and water. And we're going to be looking at the urea to creatinine ratio. And that's why. And the number we're looking for is 0.07. And if you forget what that number should be, all you have to do is know the upper limital normal of urea and the upper limital normal of creatinine. You may not know that now. I don't expect you to know it now. But you'll see that in your labs. You'll become familiar with that. So if they've got intrinsic kidney disease, a decrease in GFR, they'll go up in parallel. If they're underperfused, you'll see the urea to creatinine ratio going up greater than 0.07. If you happen to be in the United States or writing an American exam, which you would at some point, the units are completely different. And the numbers are completely different. But the way you're going to know this is to look at the upper limital normal of urea and the upper limital normal of creatinine. Moving then down to the loop of Henle then. So one of the things to remember here is I've divided the nephron in half, some arbitrarily in half. And we're going to say the proximal half is freely permeable to water. And the proximal half is the glomerulus, the glomeruli, proximal tubule, and the descending limb. And the distal half is impermeable to water, parenthetically in the absence of ADH. So we're going to look at what happens now in the loop of Henle. So this is the goal of the countercurrent multiplier and exchanger. The countercurrent exchanger is to create a medullary hypertonicity and to begin the process of urinary dilution. So we want to get the urinary osmolarity down to 200, and we want to get the medullary tonicity up to theoretically up to 1200. So we want to create these extremes. So we can, at this point, either concentrate the urine maximally or begin to maximally dilute the urine. So this is the loop of Henle, again, my cartoon. It's important to appreciate it's not drawn to scale, and we each have 1 million or so nephrons, and each one of our thin ascending limbs have quite variable lengths. The longer the lengths are, the more we're able to conserve and concentrate urine to get the medullary hypertonicity up. So we start off with an isoosmolar urine. What ends up happening here is you have an active pump. What drives this is the active pump in the thick ascending limb. And I'll magnify this in a couple of minutes. It reabsorbs sodium. Remember, there's no water moving here. So this is the key point of all this. This is what drives the whole countercurrent exchange mechanism is this. Without this, none of this would happen. So this ends up pumping sodium in the interstitium, again, without water. So the concentration starts to go up. It's now freely permeable to water in the descending limb, and water is going to be reabsorbed. And it goes up to 400, and this goes all the way down progressively, all the way up, theoretically, to 1200. And again, you just have to use your imagination to this being very long. It then starts coming back up. The thin ascending limb, remember, it's now impermeable to water, but permeable to sodium, and sodium is passively reabsorbed on a concentration gradient. There's also urea secretion into the lumen, and that urea will come back to comes from the medullary collecting tubule. And then we have more sodium that gets reabsorbed than urea secreted, so that the concentration actually goes down. And this is where this to be honest with you, it gets a bit muddy. We know that this gets, we begin to have a hypotonic urine, because if you give somebody a loop diuretic, which will inhibit this whole process, the urine comes out slightly hypotonic, but this is, we're going to say it's 280, and by the time it leaves here, it's 200. In addition, you've got this vasorecti, which go in opposite direction, and the vasorecti come from the efferent arteriole, and they are freely, the peritubular capillary, the efferent arteriole, the peritubular capillary, and then become the vasorecti, and it's freely permeable salt and water. And what happens here is that the water then moves out, and the solute moves in, down this concentration gradient, and it goes back up in the opposite direction. Specifics of this I would worry about, other than it helps maintain the osmolarity. What's important here is understanding this process here and the fact that we can concentrate the urine this way. If we look at the, to just magnify the thick ascending limb, we see the luminal co-transporters of sodium, 2-chloride, and potassium. Ammonium is also reabsorbed here, and there is potassium. Both that gets leaks back in and recycles because the potassium is going down the concentration gradient, and also gets reabsorbed. And chloride is also passively reabsorbed. To look at this more closely, to magnify this, we see this active pump goes on. You have the co-transporters that allow the sodium, 2-chloride, potassium to get into the cell from the lumen, and again with ammonium that replaces potassium in this co-transporter. And it's actually the loop diuretics that inhibit this co-transporter. They don't inhibit the active pump. Nothing inhibits that active pump. It's these co-transporters that get inhibited by the loop diuretic. Moving on then to the distal convoluted tubule, remembering that the urine coming out of the thick ascending limb is an osmolarity of 200. And here, again, is my cartoon of the distal convoluted tubule. The cell, this is the lumen, the basolateral membrane, and the luminal membrane. You get the active sodium potassium ATPase pump. And then again, you get a sodium chloride co-transporter. And it's this co-transporter that gets inhibited by a thiazide diuretic. So with this being functional, the osmolarity gets down to less than 100. So now you've gone from the thick ascending limb, which has created the osmolarity, which has allowed the osmolarity to reach 200. You get to the distal convoluted tubule, it gets down to less than 100. And this less than 100 is a critical number to remember. Less than 100. And again, as I said, that gets inhibited by a thiazide diuretic. Hydrochlorothiazide inhibits the co-transporter. So, and we'll come back to that. So looking at then the nephron up to this point, what happens is independent of what the kidney's trying to do, what the nephrons are trying to do, whether you're trying to concentrate your urine maximally or dilute the urine maximally, you have to have these active pumps in the luminal co-transporters in the proximal tubule here, the thick ascending limb, and the distal convoluted tubule. Anything that's going to affect these things is going to affect the ability to either maximally concentrate and or dilute your urine. And they allow us to create the maximum medullary tonicity to up to 1200, and then also at the same time to create the osmolarity, a maximum dilute urine of less than 100, to create these two extremes. And this is going to happen in all circumstances. In all circumstances. We then get to how we now fine-tune the urine, and we fine-tune the urine where, depending on the clinical scenario. So we start off with the urine osmolarity of less than 100, and then you get to the collecting tubule. So now what's fine-tuning the final urinary sodium is aldosterone. What's fine-tuning the urine concentration, in other words, the ability to reabsorb water, is ADH. And these two things, remember, are acting independently, but often codependently. And the stimuli for one may be similar to the other, or may be different, which we're going to talk about. Why did I do that? Potassium then is linked into this because of the effect of both of aldosterone. The sodium-potassium exchange with aldosterone. Potassium is also affected by both sodium delivery and the flow, the rate of flow to the cortical collecting tubule, and the urinary and the pH within the blood and the cells that may result in exchange of hydrogen and potassium, in particular if they're alkalotic. Titratable acids also are affected by what's happening here, hydrogen excretion rather, by the role of titratable acids and ammonia to form ammonium, to be excreted as ammonium. You get into the medullary collecting tubule, and again, you have ADH acting to continue to reabsorb water, and also now reabsorbing urea. And again, titratable acids and ammonium are excreted in conjunction to facilitate excretion of hydrogen. So looking at this more specifically, this again is my cartoon of this is the cell, the lumen, the interstitium, and the blood. The interstitial osmolarity in the cortex is going to be the same as blood, which we've called 300. And our lumen here entering the cortical tubule is going to be less, lumen osmolarity rather, is going to be less than 100. So now what happens is aldosterone is stimulated. Again, it's stimulated by angiotensin II. So whenever that neurohumoral system is activated, aldosterone will go up. But it's also stimulated by high potassium and ACTH to a lesser extent. What aldosterone does is increase the sodium-potassium ATPase pump in here. It increases the pumping of the pumps, the number of pumps, and it's proportional to how potent the stimulus is. It also increases the luminal permeability, specifically to potassium. Mouse is funny. And there's the sodium being reabsorbed, potassium being secreted. At the same time, aldosterone increases hydrogen secretion by hydrogen ATPase pump. The mechanism is not as well understood of potassium secretion as it is for potassium, but we know high aldosterone results in potassium loss, hydrogen loss. As we talked about, whenever you have a high aldosterone state with enhanced sodium delivery, as you would in the two diuretics we've mentioned most prominently, loop diuretics and thiazide diuretics, you lose potassium, become hypokalemic, lose hydrogen, and become alkalotic. Water then, water reabsorption is mediated through ADH. Remember, the two major stimuli for ADH are osmoreceptors and baroreceptors. The osmoreceptors are much more sensitive. We each have an osmostat, so if our osmolarity goes up by 1 or 2%, it will stimulate ADH. But the volume on by baroreceptors is much more potent. So point being is that you've got two conflicting signals. Someone's hypoosmolar, i.e. hyponatremic, but they're also hypovolemic, and we'll see a lot of that. And we'll discuss that again starting tomorrow. The volume one wins out, and you have high ADH levels, despite being hypoosmolar. So what do the ADH do? And again, the amount of ADH is proportional to the stimuli. They actually don't, ADH doesn't make water reabsorbed. It facilitates water reabsorption by resulting in insertion of these aquaporins into both the luminal and actual basolateral membranes. They actually create water channels. These aquaporins are inserted. They sit in the cell normally, and ADH activates their release, so they open up these water channels. And all we've done here is by opening up these water channels, and with the concentration gradient that we now have water being reabsorbed down the concentration gradient. So now you've got this concentration gradient between 100 and 300. Water channels are opened. The osmotic effect now reabsorbs water into the interstitium and ultimately into the blood. Again, reaching an equilibrium when you reach the corticomedullary junction with the osmolarity of 300. Is that a hand I see above the monitor, or is someone stretching?
Sorry, it might be a dumb question. So the water goes into the interstitium. Why does it go into the blood when the osmolarity is so high in the interstitium? Why would it diffuse into the blood?
Oh, because it's really equilibrium with the blood. Interstitium exchanges with the blood.
Oh.
And then remember, the blood osmolarity is 300. Yeah.
Yeah. Okay.
That's a good-looking pepper you're eating. I'm getting kind of jealous. I haven't had lunch yet.
Oh, did you want some?
I would have if you asked me before you bit into it, but
sorry, yeah. I'll think about it.
think about it next time, okay? Okay. It's a good thing I can't see you in front of the monitor, because I would have jumped out and grabbed that pepper. Anyway, so you then get to you get beyond the corticomedullary junction, and now you're into the medulla. Now remember, the medulla's concentration goes up progressively all the way to the tip of the medulla as maximum of 1200. And again, you continue to have this concentration gradient reabsorbing water through here. In addition, what happens in the medulla is there are other transporters, similar to aquaporins, that allow urea to be reabsorbed. And now you have urea being reabsorbed, again, through this cell to the interstitium and into the blood. And this is the other site where you have enhanced urea reabsorption in underperfused state. So there's a proximal tubule because of the physical factors, increasing salt and water reabsorption, and because of ADH here. It's important to appreciate, though, that you have more water being reabsorbed than you have urea. So in fact, your urea concentration actually goes up. Your absolute urea reabsorption will go down a little bit, but you actually get the actual concentration goes up. So theoretically, we're going to say our osmolarity when we reach the end of the medullary collecting tubule, ultimately into the urine, is going to be 1200. But as it turns out, we accept one as being anything greater than 400 as being a concentrated urine. So the number to remember here is 400 in this context. So what happens now, again, independent of our final objective here, whether you want to concentrate your urine or dilute your urine, you have to have these active pumps in the proximal tubule, thick ascending limb, distal convoluted tubule, the co-transporters to create the osmolarity down to less than 100, the medullary hypertonicity. Now you have, now we're now in the distal nephron, and you have reabsorption of sodium, end up secreting potassium and hydrogen because of the effect of aldosterone, and your urinary sodium, and finally your urine's going to come out with a amount of urinary sodium that we will be able to measure. And your ADH and your water reabsorption, again, because of the concentration gradient and the ADH increasing aquaporins, results in water reabsorption such that your urine osmolarity comes out, and we'll measure the urine osmolarity. So again, to look at this, when to maximally concentrate the urine, you're going to have high aldosterone, increasing sodium potassium ATPase. You're going to have high ADH, increasing the aquaporins on the luminal and basolateral membranes, and ADH increasing urea, such that your osmolarity, sorry, I forgot to mention that your aldosterone is going to result in your urinary sodium being less than 20. And we're defining a concentrated urine as being a urinary sodium of less than 20 millimoles per liter, and an osmolarity of greater than 400. And again, theoretically, we could say it should be as much as 1200, but we're going to accept greater than 400. And then finally, we dial in this fractional excretion of sodium, which really combines the principle of sodium reabsorption and water reabsorption. And a fractional excretion of sodium of 1% tells us they're reabsorbing 99% of their sodium and water. So obviously, if the sodium is going to be low, this is going to be low. The surrogate for water reabsorption here is the creatinine, because creatinine is going to be handled here. The more water you reabsorb, the higher the creatinine concentration is going to be. So the fractional excretion of sodium is really giving us the same information as a low urinary sodium and a high osmolarity is doing. And then we would clinically, sometimes do both. If the urinary sodium is clearly low and the osmolarity is high, there's no point in actually going to the trouble of measuring and calculating a fractional excretion of sodium, or FeNA as it's called, because we know it's going to be really low. So this is not getting to the really good part of my artwork. So hang on. So this is now the urine being concentrated. This is the urine actually. Obviously, you'll appreciate it's going slowly through the proximal tubule as there's enhanced salt and water reabsorption in the proximal tubule, and it gets to the distal convoluted tubule where the osmolarity is less than 100. And now you have the effect of ADH reabsorbing water, and you'll notice the color is getting darker. I'm sure noticed that when you don't drink much fluid, your urine is darker. And when you drink lots, it's lighter. I'm sure you guys pay attention to the color of your urine. And then aldosterone, of course, is going to increase sodium reabsorption. And again, as you get to the medullary collecting tubule, it gets progressively darker, and it's really concentrated. Yeah, it's good. I can do that in my next life, become an artist. Maybe I'll get better tools than just using the silly PowerPoint to do it. I'm sure there's other tools out there that people could use. Anyway, the net effect is this. So you've concentrated your urine, your sodium is going to be less than 20, osmolar is going to be greater than 400, and your phenol is going to be less than 1%. And that's what happens when you want to concentrate your urine. When you want to dilute your urine now, remember that everything's going to be the same. I shouldn't say everything's the same. Everything's going to be very similar up to the point of leaving the distal convoluted tubule. You'll notice in my cartoon there are some subtle changes there. We'll come to that. But the osmolar is going to be less than 100. So now what's going to happen here is you're going to have some aldosterone, because you have aldosterone in a steady state to reabsorb sodium. And now what's going to happen is because if you've drank a lot of fluid and you want to get rid of all that fluid, and you don't have baroreceptors being stimulated, your osmolarity is going to drop a little bit, and it's going to suppress ADH. And you'll have no ADH. You'll completely shut off ADH, and therefore, in the absence of ADH, you won't have any water channels, so they will remain closed. And you'll have no water being reabsorbed. No water being reabsorbed because there's nowhere to get in, and your osmolarity is going to come out as less than 100. And that's how we're going to define a maximally dilute urine. And we're going to look at these parameters when we look at somebody. We're going to talk about this when we talk about our approach to someone who's hyponatremic. And we'll go through that, obviously, later on. But important to appreciate why this is happening, a number less than 100. And of course, the urinary sodium could be variable. It could be really low. It could be high, depending on what their salt diet is. So remember, if someone's got maximum dilute urine and they're peeing, is that the case in the salt and water tutorial, 15 liters, they could have a urinary sodium of 10, which would be really low as a concentration, or 20, let's say, is really low as a concentration. But that could be a total of 300 millimoles a day. So that would be actually a lot of sodium excreting a day. So it's very important to appreciate the difference between when we're talking about total amount and concentrations. And of course, the phenol is going to be greater than 1% because mostly because the urinary creatinine is going to be low because it's not going to be concentrated. So again, looking at my cartoon, you'll notice it's faster than the previous one. If you've got a good eye, you'll notice that. It's going faster. So all that's changed up to this point is that you don't have the enhanced salt and water reabsorption in the proximal tubule. Physical factors aren't turned on. So instead of this being 70%, it's 55%. This is going through here faster, both through the vasorecti and through the loop of Henle. And what ends up happening is that you can get your osmolar down to less than 100. You can, but you're going to wash out gradients here because of the flow going through it. So if you stop this and then you try to stress them, they wouldn't be able to get their concentration to greater than 1,200. It'd be less than that. And now you have no ADH. And now you're putting in a very dilute urine, as illustrated by my cartoon. And the osmolar is going to be less than 100. And that is, and that is the maximum dilute urine. So then to just summarize again, whether we're trying to, independent of what our objective is here, we have these active pumps, proximal tubule, thick ascending limb, distal convoluted tubule, to create this medullary hypertonicity, and they create the urine osmolarity of less than 100. You know, these two segments together are sometimes called the diluting segment. They allow the urine to be diluted. And then, of course, ultimately what happens is high aldosterone will increase sodium reabsorption. ADH will facilitate water reabsorption. In addition, aldosterone will result in potassium secretion. Also, what happens with hydrogen excretion here is you don't have the carbonic anhydride that you had in the proximal tubule. So the hydrogen that is being secreted needs to be trapped with either ammonium or titratable acids, so that now they can't get out in the lumen. And what facilitates that is hydrogen ATPase, which is increased by aldosterone. So just looking at everything collectively together then, to summarize all this, aldosterone's effect stimulated by angiotensin II, high potassium ACTH, ADH, and I thought someone was texting me, but actually it's about the weather. So a brief snow shower will begin around 4:09, so you guys got to get out of here before you get wet. Anyway, the urea effect of an ADH permeability, and so forth. And in fact, linking in potassium and or hydrogen, as we've discussed, in the distal nephron. So my last slide here to summarize the renal hemodynamics. Neurohumoral mechanisms override the myogenic reflex in underperfused states. independent. The cause of the underperfused state is drugs. Mentioned ACE inhibitors, ARBs, NSAIDs interfere with regulation in underperfused states. Salt and water act as sodium reabsorption in the proximal tubule, but it's the physical factors that affect bulk, total bulk, salt and water reabsorption. The countercurrent medullary exchange is driven by the active pump in the thick ascending limb. The active pump in the distal convoluted tubule results in urine osmolar down to less than 100. And the urinary concentration is ultimately proportional to the aldosterone-induced sodium reabsorption, water reabsorption mediated by ADH in the collecting tubules. So these are the one scenario where salt and water concentration are dissociated. All the other solutes are going to be affected by water reabsorption. Diuretics, a loop diuretic and thiazides block the luminal cotransporters at their respective sites. Potassium is freely filtered, reabsorbed, but the final urinate potassium is determined by potassium secretion, and that's determined by aldosterone, pH, and bicarbonate level, sodium, and fluid delivery. Hydrogen, 90% of bicarbonate is reclaimed in the proximal tubule, facilitated by the brush border carbonic anhydrase. Distal bicarbonate requires titratable acids and ammonia. And remember, the response to an acid load is increasing ammoniogenesis. It was my last comment there. And by trapping the hydrogen in the ammonium. So this last slide actually summarizes what we spent from, I don't know what, 15 hours together in tutorials discussing. So at the very least, know these points. And of course, more beyond that. Any questions?